Ladies and gentlemen, it's my pleasure to present today a talk on the predictors of adherence to a follow-up clinic after an ICU stay. My name is Charles Preiser. I'm working in the Erasmus University Hospital in Brussels, and I'd like also to present this talk on behalf of the work performed by Daniel Prevedelo, who is a young and bright physician, Brazilian fellow in our department. I have no conflict of interest to declare in relation with this talk. So let's follow the typical journey of an ICU patient. He's at the center of the attention of many different health professionals when he's in the ICU. Then is discharged to the ward where there are less people and they have more patients to care for. So the distance between the patients, relatives, and the healthcare workers is higher, is longer, and then he goes back home and he only has his general practitioner as a health professional to talk with. During his post-ICU course in the hospital, and especially when he gets back home, he can suffer from a post-intensive care syndrome, so the famous PICS, and his family can suffer from PICS as well, so the PICS family, or the PICS including alteration in his mental health, cognitive impairments, and also physical impairments. We know that in the field of, when we work in the field of intensive care medicine, but I'm not sure that many general practitioners are well aware of PICS. Then we need to educate them on this topic. Another view on PICS, which may be helpful to understand better the high heterogeneity and variety of symptoms, is shown on this graph, on this picture, with the pain, physical limitation, cognitive impairment, perceived change in health, nutritional deficits, memories of intensive care or delusions, amnesia, ongoing disease, which is still there, the underlying disease, social isolation, anxiety, depression, stress are all different aspects that could be related to the stay in the ICU. And this is a chapter of the book on post-intensive care syndrome I had the privilege to edit with Margaret Rich and Elia Zoulay. I recommend you to get this book. There are many experts worldwide who wrote very important contributions. So in order to detect, to diagnose, and to prevent, if possible, and to treat, if possible, or to manage the symptoms related to a post-intensive care syndrome, ICU follow-up clinics were launched in different places worldwide. Many people started, and with different aims. In our ICU follow-up clinics, we defined our aims as follows. So at the patient level, we aim to assess the physical, cognitive, and mental dysfunctions and to suggest specific care and management to the general practitioner. At the level of the caregivers, which is another important aspect, the aim is to get to provide a feedback on how the patient's memories, and also to improve the practice in order to decrease the risk of experiencing discomfort by the identification and corrections of sources of discomfort. And the hospital level, especially in an academic hospital, we aim to raise the quality of care and to track problems unrelated to the admission problem, but that may occur during the stay in the ICU or in the hospital. We also aim to involve the general practitioner to keep good relations with him. So basically, what do? We start from the society. The patient is acutely ill, is admitted in the ICU. During the stay in the ICU, we try to manage and to prevent post-intensive care syndrome. The patient is discharged from the ICU. At this time, we see him and we invite him to come back to our consultation. We give, after hospital discharge, we give him phone calls, or we keep in touch with him by different media, including social media. And then we come at the consultation, and the aim of the consultation is ultimately to improve to facilitate his recovery and reintegration. So the conceptual model is also depicted on this slide with the premorbid health state, then the ICU admission, and then if the intervention and the follow-up clinic can prevent PICS, the quality of life, the health-related quality of life of the patient will improve as compared to no intervention. This is our hope. And maybe the quality of life, adjusted life expectancy, can be improved and increased by the model. Again, this comes from the chapter written by these authors in our book. There are several different models of ICU follow-up clinics. Some the led style can make a difference. It can be either nurse-led or physician-led, or as we do, a multidisciplinary team. The objectives may be multifold, including epidemiological analysis or diagnosis and referral of PICS, or treatment and rehabilitation itself. The timing of consultation can vary over a wide range from 1 month after discharge from the ICU to 24 months, 2 years after ICU discharge. The interventions can be self-rehabilitation, counseling, a personalized care plan, or specialized rehabilitation or referral to a specialized rehabilitation. And the outcomes we are willing to improve are the quality of life, the incidence and severity of PICS, decrease the risk of hospital readmission, and ultimately to decrease the social costs. This is just a picture of the timing of consultation reported by some teams who started follow-up clinics either in Australia and Canada or in the UK. So you can see that there is a wide variety of schedule of consultations. Regardless of the timing and type of consultation, we are all very happy. I mean, all implying the patients who comes back, and also the nursing team, the caregivers, the nurses, or physiotherapists involved in the program, or nurse. And this is Daniel Prevedelo, so the nice Brazilian fellow we have in the department who is working hard on this topic. So this is another picture. This patient was very bad, was almost died. This patient has twice an ECMO, etc. So these are really patients who were very severely ill and who are very happy to see the caregivers after 3 or 6 months after ICU discharge. So these are pictures of happiness. So many different ICUs in Belgium would like to start post-ICU follow-up programs across the country, regardless of the type of hospital. Centers, so 17% of the respondents have an ICU follow-up program currently running, but 86% would like to start one, but did not because of a lack of human resources or financial constraints. An underappreciated aspect is the patient's adherence. And overall, regardless of the type of follow-up clinic, about 30% of the patients come back to a consultation. We looked at our database from our follow-up clinic, and we found that 80 patients came back to the consultations, while 81 other patients withdrew their appointment or died or did not accept the follow-up from start. So we have 2 cohorts of 80 patients who were able to compare these 2 cohorts. And what comes first is that there was no difference between the adherent group and the non-adherent group in terms of demography, in terms of severity of disease, either the acute severity, although the Charlson mobility, the comorbidity index was higher in the non-adherent group than in the adherent group, implying that patients who are less sick are more prone to follow post-intensive care consultation. The length of stay in the ICU is the other prominent difference in these clinical variables. and a cutoff value of 10.5 days appears as the best discriminant factor. Mechanical ventilation for at least 24 hours and the use of ECMO were two supports that discriminate between adherent and non-adherent patients. None of the socioeconomic factors we looked at was different between the two groups. So we built by a logistic regression this model with the ICU length of stay being the most powerful factor, and the Charlson comorbidity index the highest negative predictor. Others did a similar study. This is in the UK, a total of 116 patients, and they looked at the DNA. DNA is do not attend rate, which was 44% in this case, and the days of ventilation or ICU length of stay did not differ between the group in this setting. The reasons for not attending are mostly unknown. So, to conclude, ladies and gentlemen, a follow-up consultation is really exciting, challenging, time-consuming, potentially very useful for patients, for caregivers, and for the hospital. It's, of course, multidisciplinary, requires a rigorous organization and commitment. There is a need for feedback in order to continuously improve the process, including the adherence of patients. We need a PDCA, plan, do, check, act, and then we need to pay attention to the reasons why patients may not come back to the scheduled consultation. We need to do that in order to suggest the follow-up to the best population, the most suitable patients. And I would like to finish with the list of names of collaborators involved in this project. Thank you for your attention.